Well, hello everyone. My name is Victoria Afolayan, and I'm a fourth year medical student at New York Medical College applying anesthesiology this year. I serve as the ASA alternate delegate for the New York Medical College Anesthesia Interest Group. And I am co-hosting this session with my colleague, Michael Brown, who is the ASA delegate. We are so excited to have this session, have this panel today, which is the third and final panel in our anesthesiology residency application forum. And I just wanted to say a good evening to all our guest panelists, the prospective applicants, and everyone who is watching this stream today. The goal of these forums have been to provide applicants with information about the application process, learn more about the wonderful anesthesiology programs joining us today, and answer any questions that you may have about the upcoming application cycle. It's a very anxiety-ridden process and time for a lot of us right now, and we hope to provide some transparency on the process. Before we start, I also want to thank our guests for being here. We are joined by Dr. Judith Aronsohn, Program Director at Zucker Hofstra Northwell Health, Dr. Joy Schabel, Program Director at Stony Brook University Medical Center, and Dr. Michael Block, Program Director at Hackensack University Medical Center. Now I'll pass it over to Michael.
Thank you, Victoria. Hello again, everybody. Like Victoria said, my name is Michael Brown, and I'm also an M4 student. I serve as the ASA delegate for the Anesthesia Interest Group at New York Medical College this year. So we'd like to invite all of our participants watching live to join us on our Slido link, and the access link will be sent in the YouTube chat. And you could use hashtag New York Medical College -AIG. Again, that's NYMC-AIG, where you could ask questions during the event and vote on which questions you'd like us to ask the panel at the end. And you'll have the link in the YouTube chat. Again, just note that we might not get to all the questions posted on the Slido, but we will try to cover some new questions that we haven't asked yet. So before we get started on asking each program their questions, I'd like to give each program 2 to 3 minutes to introduce themselves and their resident physicians joining them, and provide a little brief overview of their respective programs before we get to our submitted questions. So I think this will be a good place to start with Dr. Judith Aronsohn, the Program Director at Zucker Hofstra Northwell Health.
Hi, first of all, thank you for having me here. I'm Judy Aronsohn. I'm the Program Director at Zucker School of Medicine at Hofstra Northwell. To give you just a brief synopsis of our program, we are a relatively new program. We've got accreditation about 8 years ago, so we graduated about 8 classes of residents. Our program is relatively small compared to our training campuses. Residents train in both a suburban and an urban environment because LIJ, one of our 2 major tertiary centers, is in Queens, and our residents get huge exposure to huge diversity, not only of cases, but of patients. I mean, if you know anything about the Queens population, you know it's quite diverse. And then we have North Shore University Hospital in Manhasset, which is, a 5-minute drive from here, also a tertiary care center, where the population is a little bit more suburban, and that's where we do all of our transplant and our cardiac cases over there. So we feel like we give our residents broad exposure to tons of things. And I had the privilege of being able to start a new program here. And through these last 8 years, we've gone through a tremendous amount of growth and development based on every resident class that comes in and the changing environment in healthcare in general. I have a wonderful chief resident on the meeting with me, is Elliot Klein. So I just want to add that any questions that you have for me, you can also address to our chief, because he may be able to give you a much better resident perspective than I can, depending on what it is you want to know. But I'm very, very pleased and privileged to be here. So I'll now pass it on to Dr. Block. I'm assuming he's going to be in alphabetical order the next one.
Thank you. Thank you, Judy. It's great to see everybody. And thank you for having us as well. It's great to be here. I'm here with Dr. Deedham Tan, who is our chief resident as well. So a little bit about Hackensack University Medical Center. I've been in Hackensack for 25 years. We are a large quaternary care medical center located in northeastern Bergen County, right a few miles from the George Washington Bridge. So we're essentially a suburb of New York City, but in proximity to all the other major gateways of central Jersey and even Philadelphia. Our program, I'm also the founding director of our program. We got accredited in 2018, and we just entered our first class in 2019. Starting in the categorical year. We are a categorical program, starting in the preliminary year. So all 4 years of training takes place on the Hackensack University Medical Center campus. We just graduated our first class this past June. We are a small program as well. We have 4 per year, although we certainly, like many other programs, have the capacity to support more trainees. I'm also the director of OB anesthesia. A little bit about Hackensack. We're about a 900 and growing bed university medical center. As I mentioned, all the training and rotations from the preliminary year in internal medicine through the CA3 year all take place at Hackensack. The first year is based in internal medicine. We are a level 1 trauma center. We are a large children's hospital. We are a perinatal referral center. We are a huge orthopedic center, and it's just growing and growing. We just opened this past December a brand new surgical tower, hospital tower, which has 24 new operating rooms, which are all state of the art. All the patient rooms are private with new ICUs. So as Dietem can tell you, it's an enterprise. And that's pretty much like all I can think of at the moment. I'm happy to take any questions and have Dietem, share her perspective.
I guess
I think up next is Joy Schabel. Yes.
Hi, I'm Joy Schabel. I'm the program director at Stony Brook. Stony Brook is located in Suffolk County. So for those of you sort of new to this area, if you cut Long Island in half, we're on the more east half of Long Island. We are a 4-year program, so the internship year is included. We have a total number in our class per year is 12. This program is pretty old, probably over 40 years old, and has grown in time. I think I'm in the 4th or 5th program director here. During our clinical base year and in our anesthesia years, pretty much most of the training occurs here at University Hospital. We're pretty much the only large, huge academic level 1 trauma center in this community here in our Suffolk County. And Suffolk County, if you go from end to end, is about 100 miles in diameter, because Suffolk County goes all the way out to Montauk, if you're familiar a little bit with the geography, and then it goes to the west to about the Melville area. So it's a pretty wide catchment area. We get to see everything here. We don't farm out anything. If anything, all the community hospitals kind of farm their higher risk cases and trauma to us here. So our residents really have a really strong training in terms of diversity of cases and complexity of cases. I don't want to take too much time because I also wanted to have my resident Kalisa just introduce herself because she's with us this evening.
Hey everyone, my name is Kalisa. I'm one of the CA3s of the Stony Brook University Hospital program. I am also one of the chief residents of education. I'm glad to be here. I guess a little bit of background about me. I'm from California. I made my way to Richmond, Virginia for medical school at Virginia Commonwealth University. And then here I am at Stony Brook for my anesthesia training, and it's been a great time. I look forward to your questions.
Okay, so the first question is, what about your program are you most proud of? Are there any areas that you have identified that are not as strong and are working to improve? And I'm going to have Dr. Aronsohn address that first.
That's more than one question, actually. But anyway, what I'm most proud of is actually our residents. I consider myself very, very lucky, particularly because we were a relatively new program starting out, to have been able to attract every single year the kind of motivated, bright, and diverse medical students that we've been able to match. And they are very, very diverse, highly motivated, cohesive group that have made me very, very, very proud to be their program director. I don't know how else to put that. They are really my pride and joy. So the thing I'm most proud of is the residents and how they've helped me take something that was nothing in the beginning and build it into what I consider to be a very successful program and a great, great place to train. They're the face of the program. It's not me, it's not the faculty, it's really, really them. And it's all about them. If I have to identify an area that I think that we need the most work is, I'm going to say, one of the areas that I would like to see grow is we have two new fellowships that are associated with our core program, but I found it difficult over the last few years because of the shortage of anesthesiologists out there and the great salaries and benefits that are out there now for graduating anesthesiologists. I'm finding it more and more difficult to garner an interest in doing fellowship, which I think is very, very important. You know, I put a lot of emphasis on furthering education and seeing where this specialty is going to be 5, 10, 15 years down the road. And everything is just so attractive out there, including for my residents once they graduate, that getting them interested in becoming really subspecialists in some area of what I consider to be the best field in medicine is getting more difficult. So that's one of the weaknesses. I think it's more of a personal weakness, maybe of mine, that I would like to improve upon in the program, is getting more of our graduates to do fellowship.
Okay, thank you for that. And can we have Dr. Block?
Sure. So I would say that I'm most proud, as Dr. Aronsohn said, about our residents. And what I've noticed, especially this year as we graduated our first class, is the extreme gratification that I see of how accomplished they are. They work hard. We all work hard. The days are long. Sometimes the nights are busy. But when I see, you know, a CA2 or a CA3 orient a CA1 one-on-one, and I just kind of observe and I see what they know and what they learn and what they're teaching, it's just mesmerizing to me. When I see the fellowships that 3 of the 4 of our graduates went on to, and the job that the other individual decided to take as opposed to a fellowship, that's rewarding and what warms my heart all the time. And so I would say also it's our residents. I'm also proud of the fact that I think a big strong point of our program is we have a sense of family because we're a small program, not just amongst the faculty, but the nurses, the support staff, you know, everybody that we interact with every day in you know, across 24 operating rooms plus, you know, the others, is really a sense of collegiality and just the friendliness when you walk through the halls. And I think that's really important, you know, for a program. Like Dr. Aronsohn said, I think that I would like to see, if I had, you know, my druthers, not only fellowships, but I'd like us to have a larger program, 4 per year for an institution that does, you know, 50,000 anesthetics per year and, you know, 6,000 births per year. Is great because the residents have complete access to, you know, high-level cases very early on. But I think the presence of a larger class, you know, not 20, but maybe, you know, 6 or 8, plus fellowships, I think would sort of add to the richness of our program.
Okay, thank you. And Dr. Schabel, can you go next, please? Thank you.
Sure. You know, I'm going to echo the response of Dr. Aronsohn and Dr. Block by saying, yeah, I'm most proud of my residents. Maybe that's why we're all PDs, right? We love our residents for many reasons, though. Part of it is certainly their clinical skills. If I would come in as a trauma alert and look up and see one of my residents about, you know, opening the laryngoscope, already push propofol, I don't need any verse ed because I'd be relaxed about, okay, I'm in really good hands here. I'll close my eyes, open my mouth and let them go ahead and just do their thing. So certainly the skill sets, their accomplishments, when they're all done clinically, academically, all of that, but also just the people. I don't know, maybe I just get really lucky that the residents who come join our program, they're all very different backgrounds, different ages, really lots of differences to them. But they really tend to adapt to that whole feeling of like team, working together, being a family, which Dr. Block mentioned as well. Maybe it's the size of the program. We're not super huge, 12 residents per year. It's just doable where It's not super small where they feel like they have no friends. It's not super huge where there's people who don't know each other. So it's really nice to see at graduation them hugging each other, or they're going to weddings for one another. One of our attendings currently, who was a former resident, he just went to Scotland to watch one of his former, residents get married. And then I learned he was like texting me and say, "Oh, we have like 6 out of the 10, because our classes were 10 back then, over in Scotland attending the wedding of Trey, who's one of his co-residents." So it's just really wonderful to see both competence, accomplishments, and the friendships that really develop over the course of residency.
All right, thank you so much. I think it's really amazing to hear about the appreciation of residents in your programs. It's definitely not something to take lightly in a residency program, and just like the communication and the community that you guys have in each of your programs. That's great. I'm going to go on to the next question, which is, as we enter year 4 of virtual interviewing, what have been the biggest takeaways on how the shift to virtual interviewing has affected the interviewing process? And can I have Dr. Aronsohn?
Sure. At the beginning, I was very disturbed by the virtual interview process because I really, liked being face-to-face with an applicant. I think that though the loser in the virtual interview process is more the applicant than it is, the program director or the interviewers. And that's because there's a lot that an applicant picks up by walking through the front door of your hospital, coming up to the interview area, meeting people, who are coming in and out of the anesthesia office. There's a feel that they get by, walking through, taking a tour, going down to the OR, interacting in that kind of venue and environment that you don't get in the virtual, when you're sitting in a virtual interview. It also has obviously affected all of our numbers of applications, right? Because now that we're virtual, the medical students and even people applying for an R spot are sending out way more applications, so everybody's getting more applications. So it's become busier and a little bit more difficult to do the kind of holistic review that we want to do of applications, because we're looking at so many more now than we were before when we were live. But I've adapted to it myself. I just hope that the students have. And I don't think in the long run, though, it's really hurting anybody that much. But that loss of feeling, what everybody is like when you walk in the door, getting a feel for how everybody interacts with one another. And you get that feeling, even though you're just coming for an interview, you come up to the office, you have lunch, in a live interview, arena, and, other attendings walk in and all the other residents come in. That is just priceless as far as I'm concerned, and something that I am really, really sorry that not only for our program, but for every program, that the applicants who are interviewing everywhere are missing. So there I go.
Thank you for that. And can we hear from Dr. Block next?
Sure, I agree also. There's nothing like an in-person interaction. I feel the same way about our conferences. We're now more in person and hybrid, but there's really, the social interaction, just being around people, in non-virtually, is just a new reality. And I think what I do like about the virtual interviews is the convenience. I think if I were an applicant now, having not to travel and stay over, and the cost and the burden with traveling, I think is a plus. And we're adapting to it as well. So I think it's here to stay, and we just go with the times.
Thank you. And Dr. Schabel, do you have anything to add about that?
No, I would just agree to what both Dr. Aronsohn and Dr. Block said. You adapt. We're anesthesiologists, right? We're versatile. So you get put in a situation, you make it work, and I think it's okay. I like the savings for the students, for sure. There's some students used to take $7,000, $8,000, depending on what specialty they're going into, depending on what savings they had, if they were applying all over the place. So I do like the cost savings, because otherwise I thought that was, not maybe the best use of money perhaps. But yeah, we adapted, we make it work.
Thank you for that. And I echo what you're saying. As applicants, it's great to not have to spend, extra money on traveling, but we do have to find other ways of evaluating programs since we don't get that in-person feel. But yes, I'll pass it on to Michael.
I think this is a great chance to switch and hear for some of our residents joining our panel today. So the question I have is, are there specific values or qualities promoted within your program? And as a resident physician, do you get a sense of team culture at your program? So we could start with Dr. Zhang.
All right. There's definitely a great culture at Stony Brook. I think, like Dr. Schabel said, she does a great job selecting residents, and I feel very fortunate to be very close with my co-residents and now also our junior residents. There is such a great community among us, and I think part of it is the class size. Currently my class size is 10, but we recently have gone up to a class size of 12. But I think that class size is kind of in that sweet spot where it feels almost like a big family. You have a lot of different personalities that can interact with each other, and you can learn from a lot of different backgrounds, but it's still close-knit enough where you really get a good opportunity to get to know everyone. I think that community also applies to the attendings as well. Some of our attendings we build really great relationships with, even outside the resident kind of mentor relationships that, in the professional aspect, but a lot of our attendings we get very close to. We start calling them by their first names. We hang out with them outside of work, and overall it's just a very warm and inviting culture all around. I think Stony Brook definitely has those traits of inviting people who are just welcoming, nice, kind people, and who generally work well in multiple settings with multiple people and a diversity of different scenarios.
Thank you so much for that answer. And I think now's a good time to switch to Dr. Tan.
Hi, so in our hospital, we have residencies from many different specialties, especially for anesthesia. We are a team worker, not in the OR, but as a consultant for other specialties too. We have a close relationships with other residents and surgeons. That helps us in terms of approachability to the attendings or surgeons and advancing our learning opportunities. Just for anesthesia wise, our classes relatively small. It helps us to build better connection with each other. We all have different characteristics. We have all our individuals, different characters and from walks of life. That helps to build relationship with the patients too, because we learn from each other and just develop our skills every day.
And on to Dr. Klein.
Hi. So I think this question actually ties back to the first question you asked about, what would I be most proud of for our program? And then Dr. Aronsohn answered the residents, but for our program, but I want to answer the faculty. I think that our program really has outstanding faculty, the collegial atmosphere and the warmth that we receive every day going to work and working in what we feel is a safe environment, easy to learn, relax with appropriate accountability and appropriate autonomy. Really makes for a great learning experience and a great relationship with the attendings, to the point where they take us out, for dinner, they'll have us over to their house, they buy us food on call. We have such a fantastic relationship with our faculty that, coming to work and learn, and working and learning feels like a seamless experience, and built into that is the resident wellness that we have built in as well. So we combine those factors, and I think that's something that I'm most proud of as well as our program.
Hey, thank you. And I have one more question for the residents. What does a typical day at your program look like? And do you feel there are enough structured and unstructured learning opportunities? And I'll start with Dr. Klein again.
Sorry, can you please repeat that? You cut out for a second.
Yes. What does the typical day at your program look like? And do you feel there are enough structured and unstructured learning opportunities?
Oh yeah, absolutely. We have a very diverse learning experience. We don't farm out anything. All cases are kept between our two hospitals. We do different specialties between our two facilities, but we do everything from cardiac peds to peach transplants to livers, lungs. Very diverse caseload experience. The average day, typically, most cases start at 7:30. Residents usually come in a little bit early to set up. Our techs help them set up the room as well, which is great. You'll see your patient. Present your patient to your attending. You usually discuss the night beforehand, progress through your day, and usually get out between about 4 p.m., 4 to 5 p.m. latest on a regular day. Built into that is obviously a call schedule with a pre-call schedule as well. And usually about 3 calls a month for us, which is very reasonable. And yeah, the diversity that you encounter on a day-to-day basis it's a mixed bag. You really don't know what you're getting unless you're on a dedicated rotation. For the general OR, really keeps you on your toes and makes you learn every day.
Okay. And I'll repeat the question just one more time. This will be for Dr. Tan. What does a typical day at your program look like? And do you feel there are enough structured and unstructured learning opportunities?
Yeah, so every day at around 4 p.m. we get assignments for the next day. That helps us to read about our patients and prepare for the next day. And the first case is usually scheduled at 7:30. We arrive before 7 usually, set up the room and discuss the case with attending. So we have the opportunity all day to discuss the other patients as well. But we also have the opportunity to ask to be assigned a certain case if we are interested in it before 4 p.m. So when we look at the schedule, if there's something interesting to us or possible publication opportunities for that case, we have the luxury of being able to participate in that room. Every resident has an assigned blocks, like I'm sure it's the same in every other residency programs. But in case if you want to have more experience, if you're in general rotation and you want to do more complex cases in obstetric, for example, we have a lot of per creda cases. We have the opportunity to be assigned those cases as the schedule allows. Our days are usually ending at around 4:30 and we are relieved on time. If the long call person in the room, we typically get trauma cases every day, so we can be put in those rooms to have more experience in trauma. That's a little bit unstructured, but it helps in terms of managing unpredictable cases.
Thank you. And Dr. Zhang?
So I think our day-to-day flow similarly mimics the flow that Dr. Klein and Dr. Tan spoke about. So usually the afternoon before we are sent out the schedule, we'll look up our patient and pre-op with our respective attending, kind of discuss the case and any specific considerations. Then usually sometime in the morning, our case start is also 7:30 as well. So depending on the complexity of the case or even just comfort level on the resident's part, they can decide how early they want to come in and how much time they want to have to set up in the morning. We'll be on our way by 7:30, and most days I would say we would average around 3-4 o'clock. Of course, some days are busier and some days are lighter, just kind of depending on the caseload. But we do have a night float system in place, so the absolute latest you would get out would be 6 p.m. when the night residents do come in. In addition to that, we do employ almost like a late person kind of just like tally. So residents who do maybe stay at a little bit later, 5-6 p.m. Their names are written down. That way we can try to get them out a little bit earlier the next day, and that kind of balances everything out, makes it even. In terms of the structured and unstructured education, I think we definitely have a good mix of both. We have some attendings that are truly, truly passionate about teaching, who go to very far lengths and really emphasizing education in the OR, making handouts about like cardiac cases. There's one attending who classically will ask you the night before, okay, what do you want to talk about tomorrow? And then you're kind of quickly looking up a topic, and that way you can teach it back to them. So definitely unstructured learning is there. And I think our structured learning is also unique in the sense that every third Wednesday, we have a completely non-clinical day that is completely filled with didactics and a mix of simulations and QI projects. And it's really nice to just be able to focus on learning for an entire day. You don't have to worry about patient responsibility. You don't have to worry about pre-authing and all that. So you can really just focus on learning and taking that time for yourself. And I think it's also kind of a nice change of pace and mental break. So yes, I would say we have a good mix of structured and unstructured education.
Thank you so much for those wonderful responses. I'm going to give it back to Victoria now so we could hear a little bit more from our program directors joining us on our panel today.
Okay, so the next question for our program directors. This cycle of applicants are the first year applying with step 1 being pass-fail. What will change in your evaluation of these new applicants without that added metric of a step 1 score? And can I hear from Dr. Aronsohn? Thank you.
You know, I would say nothing, but that wouldn't really be honest. You know, I think, you know, there are things that will change. It's a kind of a loss of something that we've always kind of depended to be part of our algorithm for sending out invites for interviews and ranking and everything like that. And it's going to take an adjustment to get used to not having it in terms of the way we've all in every specialty used it in the past. That's not to say that we haven't historically done a holistic review, because as a newer program, we've always had to, whether we wanted to or not, really do a holistic review of all the applicants. But I think that along with the loss of step 1, there has been a propensity among a lot of the medical schools also to get rid of, you know, more than just step 1. They've, you know, some of them don't give you a lot of information at all. You know, they're getting rid of grades, or they're, you know, getting rid of class ranking. They're getting rid of rotation, you know, grades and comparative scores for rotations. So I think that one of the things that is going to change for us is that, you know, the rigor of the medical school performance evaluation is going to take on more importance this year for us than it probably did in the past. The importance of the step 2 score will take on more importance than it did in the past. All the other things that we highly evaluated and put a lot of weight on, like, you know, other educational accomplishments, you know, life experience, those will all still be just as important as they've always been. You know, one of the things that I have always put a lot of importance on is a personal statement. It's one of the things that, for me, you know, I find useful in getting some insight into the, lack of a better word, sometimes the soul of the applicant, and it really tells me something more personal about the person. Those will all still be highly, you know, scored on in our metric system for, you know, sending out invitations for interviews and maybe ranking at the end. You know, when you get to the ranking, you've already got, you know, a lot of information that you'll mix and match. But you know, I think, to be honest, those are the things that are going to be affected this year with no step 1.
Thank you so much for that insight. And can we hear from Dr. Block?
Sure. So for those of you that know me, I like to be a little controversial, but I think that I never felt that, you know, a board score was a predictor of success in a residency program. It's just my personal opinion. I know that there's a lot of different opinions out there. My son is now studying for his MCATs, and it's all about the technique and the strategy and the game of how you take the test. And it really has very little to do with your goals or aspirations. It's a game. And so I've always looked at applications holistically. I tend to put a lot of weight on how students do in their third-year rotations. I feel that that's sort of a predictor when they're starting to interact with house staff, how they're starting to apply knowledge that they've learned in the first 2 years to a patient. And so I like to look at the shelf exam. I like to look at the details of what people say about them in their third year, for those reasons. there's a lot of variability with information that we're getting from the medical schools. Like the personal statement, we put a lot of weight on the interview because this is the person that's going to be with us for the next 4 years. And I think the interview does a really good service for both the program and the student to make sure that it's a good fit. That's essentially what the match is. Is it a good fit? Is this person, do we want to be on call with this person? Do we want to work side by side with them? Do we want them to work for us when they're done? And so we found that formula to be pretty successful as far as, retention and recruitment. We've seen, a few residents who have had marginal board scores who were, phenomenal and have gone on to, gotten great fellowships. And so that's my opinion. So I'll turn it over to Dr. Schabel.
Yeah, I don't think, in my opinion, I don't think not having step one has changed things too much. Before step one was pass fail, it was not unusual to see many applications with just one step score. They just would have step one. They wouldn't take step two till January, February, or even later, because they just didn't need to if step one went well. So for many reasons, we were kind of used to sometimes seeing only one step score. Now we only have one step score to see. So my personal opinion is it didn't change things too much. I think for most programs, the step score is one part of the application, as the other program directors have been mentioning. It's one part. There's the third year clerkship performances, the narratives, the letters, the personal statement, the activities, the research. There's all these other sorts of things, and of course the interview. So I think it's just a small section, and converting it to pass fail, I don't think is going to make a huge impact.
Okay, thank you so much for that. Our next question kind of goes off of this a little bit. You might have kind of touched on this question, but let's say an applicant has a poor step two score. What recommendations do you have in terms of reaching out to you about that? And would it be a deterrent in their application? And does your program have cutoff values for step two scores? And can we hear from Dr. Aronsohn?
We don't have a cutoff for step two. And what we've been trying to do, particularly this year, I'm trying to do this better than I've done it in the past, is really take all of those things that I mentioned before and that all the program directors have mentioned before, including a step two score, and give it a certain numerical value. And as we go down that list, to make it more of an unbiased type of review process, assign everything a score and add that thing up at the end and come out with a final number. I'm talking about just now getting from the application to the interview. The interview, once you're in for the interview, it's all about the interview as far as I'm concerned, right? It's, you've gotten through all those other metrics. And now it's time, it's show time. Not that I mean that an applicant's putting on a show, but it's time for us to feel, to see whether or not you're going to be really happy here and this is a place that you'd like to train, right? So I'm really just addressing the first part now. So if an applicant has a poor step two and they think somehow it's going to hurt them, this is a program they're really interested in, and they really want to interview here, there's signaling, there's sending an email, there's all kinds of, it's a little bit hard now to say, try to get a rotation here and, show us what you're all about. But I wouldn't rule yourself out because you don't have a great step two score. Step one didn't tell the whole story, step two doesn't tell the whole story either. And there's lots of other things in that application that you have to be proud of. And if you don't think that a particular program that you want to interview at has noticed that, reach out to them. I don't mind when people reach out to me and want to bring me back, to pay some attention to their application. So that would be my advice to somebody at, late in the game who doesn't have a great step two score. If they're further back, if they're if it was further back in the season or they were a third year medical student, I would say, if you really like a program, see if you can do an elective there, and get to know the program more and have them get to know you more. And that's a great way to, show your interest and do your best to come to the attention of the faculty and the program director in a particular program that you may think you really like.
Thank you. And Dr. Block, do you have anything to add to that?
No, along those lines, we don't have cutoffs for step 2. You know how I feel about step 1, but you know, again, we look at things holistically. You know, many times when an applicant will get to the interview, or sometimes before the interview, they'll say something in their personal statement about a low score. Maybe there was something going on in their life or whatever. So I try to find out what was behind it if it's a concern, but we don't toss the application, or you know, if the score is low. So that's, you know, that's my opinion.
And Dr. Schabel?
Just very similar answer. It's one part of the application. We look at the full application. If there was a particular event or something that occurred, like Dr. Block said, feel free to, if you feel comfortable talking about that either somewhere. I think you guys have like an impactful, some questions there. If something of a huge impact happened in your life, whether personal or health-wise, whatever it may be that you feel comfortable talking about, that maybe have impacted your performance on a standardized exam, don't be shy about putting that in there, as long as you feel, you know, comfortable about it. And with anything in life, it is what it is. You make the best out of all those other sections. Your personal statement should be clear, no typos, show positivity, show resilience, you know, all the little activities that you have. Don't just write one sentence. If you spent 3 years doing research in infectious disease, you know, write about it, and really, so you can communicate your full parts of you as an applicant.
Thank you so much. And I'll pass it on to Michael.
Hey, thank you, Victoria. And I have another question for the program directors. Dr. Schabel, I feel you're going last every time, so I will pick you first this time. Could you tell me how will program signaling and regional preference be used in application considering at your program?
I think it will mostly play a role in the interview invites. I think it's great, the signaling. It gives the applicant an opportunity to communicate to the program director other than email about geographical preferences. Sometimes they're getting married, or their significant other got a job, got transferred. Normally, there's really no place in an application to put that, unless somebody would put that in their personal statement. But with the signaling, all of a sudden, if you have someone you know, zooming in a certain geographical area, that is a way of communicating to the program director that, yes, I'm interested in matching and working in that area. So overall, I think it will help with the communication to show interest, which will help probably in the interview yield. I'm not sure if it will really make that much of a difference in the final match of things, match ranking. As Dr. Aronsohn said, often once you get to the interview stage, it's about the interview and how people feel the applicant will, you know, fit in their program. But my answer will be it's mostly helpful for interview selection and communication of personal information.
Thank you so much for that answer. And we'll transition to Dr. Block. Again, I'll repeat the question for you. How will program signaling and regional preference be used in the application considering at your program?
Much in the same way that Dr. Schabel mentioned. You know, we find that a lot of the people that are attracted to our program are ones that are from New Jersey or from the tri-state area, either themselves or they now have ties to the area, either family or spouse or significant other. And so we find that to be a predictor of success for our program is regional preferences. You know, it's not Miami, it's not Hawaii. So people are usually coming to us because they have ties to the area. And it's amazing to see how many people out there have some connection to New Jersey. So like Dr. Schabel mentioned, we use it for interview selection as a guide. And I think it is helpful. I think it is helpful.
And Dr. Aronsohn?
Yeah, hi. I mean, I think we all know that probably the number one reason that applicants give for, in general, for applying to and ranking programs is location, right? So location is very important to the applicant. So clearly, you know, for the program directors, they're knowing their desire to either be in your area or not is going to be important for asking for an interview. In terms, and at least that's always been important to us as well. I mean, I love to have a diverse group of residents from all over the country, but as Dr. Block says, a lot of residents really have a preference, or medical students really have a preference for being where their family is, or being where their significant others are, where their support system is. So, we look at that very closely. If you have a particular interest and you want to be in the area, of course, that speaks to us louder than somebody who does not. In terms of the program signals, I also think they're very, very useful. And I'm glad that applicants have the silver tokens this year. As in addition to the gold next year, we will definitely be looking at those applications very closely. I don't know that we will be inviting people to interview who, we wouldn't ordinarily also invite for an interview, but we are definitely going to go through any signal, any application from a program signal that we get is going to be, reviewed thoroughly, regardless of, the other metrics that they have. Because I think that if an applicant is showing interest in us, that I owe it to them to show that special interest in them as well. So those, I think, program signals will be very important in the upcoming interview season.
Okay, thank you. And now to switch to hear a little bit from our residents. So a question for the residents, we'll start with Dr. Zhang. How does your program respond to resident feedback and suggestions? And are there any specific incidences where your program has changed in response to that feedback?
Yeah, absolutely. So I mentioned our academic Wednesdays earlier. Every third Wednesday we have the non-clinical day. Part of that day we do sit down and have lunch with either Dr. Schabel or our chair, who's currently Dr. Shaw. And so every 3 weeks we have a chance to address any issues or discontent that we have encountered. And because it's on such a regular basis, I think we can almost have like a preventative or prophylactic approach to that. And so I distinctly remember there was one day, I think maybe my class had a couple more grievances, and Dr. Schabel brought out her pen and paper and wrote them down, 1 through however many. And the next day we got an email again reiterating all those same things that we brought up the day before and exactly what she did to address them. So I think she's truly been amazing in terms of listening to us and responding, especially in a very quick manner. Like not even a day turnover is truly amazing. Just to give an example of one of the things that we have been discussing, one of our rotations is the cardiothoracic ICU. And so it's a shared rotation with the surgical residents, and the scheduling can get a little complicated because of that. And that's kind of what we've been discussing currently, going either through a 24-call system or transitioning to a night float system. And that's still currently in the works. But as I'm sure you guys know, it changes, particularly between 2 different departments, can be very slow sometimes. But we, I think, at least try to start and get the ball rolling very quickly. And we could not have done that with Dr. Schabel. So she's truly been a huge asset to our program.
Thank you so much for those words. And I'll shift to Dr. Klein again, and I'll repeat the question. How does your program respond to resident feedback and suggestions? And are there instances where your program has made a change in response to that feedback?
Yeah, I think feedback starts at the top down. Dr. Aronsohn, our PD, has an open door policy. Her door is literally always open. Residents feel super comfortable walking in there and just talking to her about life and anything or any complaints they have. And she always has listening ear and addresses that. Additionally, we have on the resident side, we have a submission form, and anytime residents can submit any complaints, it's addressed right away by the chiefs and passed to the correct place to get addressed. And then on top of that, we have a quarterly meeting in person with all the residents, and we have pizza or some other food, and we get together and we hear any grievances or compliments or any other stuff that we want to discuss. So there's plenty of avenues for resident feedback, and resident feedback is immediate. Dr. Aronsohn takes it very seriously. Some Some instances of that would be, for example, residents wanted increased education. We typically, up until this year, we had education about once a month. We have a dedicated day. In the morning sim, afternoon lectures. We now increase that. Every class now has an increased quarterly education day, which is fantastic. Dr. Aronsohn protects the interns in a way that is very unique as well. Our interns are anesthesia interns, and on their rotations, on their subspecialty rotations, if they ever have any problems, they can always turn to us, and she responds immediately as well. So feedback is taken very seriously, and our intern year, our education, and our whole program in general has grown tremendously under her because she incorporates feedback pretty much instantaneously.
Okay. And next, Dr. Tan, how does the program respond to resident feedback and suggestions? And are there instances where your program has changed in response to that feedback?
So about every month, we have town hall meetings. Every resident, each class, and our program director, we come together and discuss some of the things that we can improve on, or our concerns, or some suggestions about the lectures, or anything that residents have problem or request for. About every month, we go over those things, and they work on it. And one of the examples that I can give you about the changes they have made so far is our graduated class last year had made a request about the call schedule. Normally they did have a 24-hour call schedule, and that was really tiring for the residents, and they requested to change it to a 7-day night float system where they have 12-hour shifts for 7 days, about every 4th or 5th week. I have not experienced a 24-hour call schedule, so I can't really give you like my opinion about the difference between the two, but I can say that the residents love it. It is less tiring, and it gives us more opportunity to work on other things. Either we research during the day, so we have extra 12 hours to work on other things in our lives. But they acted on that really quickly, and the next following year, we had the new night float system. And I can also give an example of some of the things that we do is we have a categorical program. So our interns rotate with internal medicine department doing their internships. Every year at the end of the year, we come together and we ask them if there was anything that they wanted to be different, whether the rotations they have been to, whether they were helpful for their anesthesia rotations in the future. So we talk with the internal medicine department, and we make some changes in the scheduling, whether adding rotations or increasing number of intensive care rotations to help us to build more foundation for anesthesia.
Thank you so much. Now back to Victoria.
Okay, this next question is for our program directors. What type of cases should a resident expect to be involved with at your program? How are these cases split between the residents and the fellows? And can I hear from Dr. Block?
Sure. So unfortunately, we don't have fellows, but fortunately, we don't have fellows. So our residents have access to all kinds of fellow level cases. Our schedule is made according to a progressive, complexity of cases. So obviously in the CA1 year, the first half is focused on more simple cases, outpatient cases, general cases in the operating room. And as the residents progress, we then advance them to more complex cases, such as vascular and thoracic, and all the subspecialties in the later half of the CA1 year and in the early part of the CA2 year. So they could expect we do a lot of robotic cases at Hackensack. So they, can do a robotic prostate, or, we do a lot of bariatric cases. So they're very good at, airway management in morbidly obese patients. We have a very busy kidney transplant service. They can, teach me about kidney transplants. So they're doing anything and everything. We have a NORA rotation, which is non-operating room anesthesia. So the residents in their CA3 year will go off the floor with an attending one-on-one, and they'll do sedation cases and endoscopy and MRI. It's a very big part of anesthesia practice now. We also have a very busy OB service. So in the CA2 and CA3 year, by the time they're, it's their second month in OB, they're going to be doing epidurals with indirect supervision and C-sections. They'll be doing procreta cases. So I think just the breadth and diversity of cases that we have, everything up to excluding heart transplants or pediatric hearts, they get. And because of the volume of cases, the majority of our residents meet their requirements by the middle of their CA2 year.
Wow, that's wonderful to hear. And can we hear from Dr. Schabel next?
Sure. We assign our residence cases based on a block rotation schedule. I do have one here. I'll put it up to the camera. I don't know if you can I don't know if anybody, can kind of see what it is, but lots of little squares, basically a lot of little abbreviations representing all the different rotations. So classic CA1 rotations would be GU, GYN, plastics, ortho, general, ENT. That's the first 6 months of the year. Once we hit January of CA1 year, or even a little bit before for OB, we start to send the CA1s to some of the subspecialties. So OB, they can go to acute pain, cardiac. If they've had cardiac, then they can go to CT ICU. So we progressively increase the complexity of the rotations as they, move throughout residency. Certainly in the main OR, by the time they are a CA3, they're going to be doing the Whipples, the FIOs, the terrible airway type of cases versus a CA1 who's just starting and is learning, very basic sorts of skills. We have a coordinator, anesthesia coordinator, who does the schedule for the next day, looks at the big picture, looks at the block rotation to see who's on what, so they can assign the resident to appropriate cases. And with the block rotation, it ensures that all residents will have ortho, GYN, GU, like exposure to everything by the time they graduate. Nobody has to remember who did something yesterday because everyone follows the block schedule. We do not have fellows in University Hospital. We do have 2 pain fellows, so they're at the pain center. So at University Hospital, any of the complex cases goes to the CA3s, because there's just really there's no fellows. So acute pain, if it's a really tough block, the CA3, or it could even be the CA2 if they're on the rotation and if they're the only resident on the rotation. So lots of opportunities to grow their skills throughout residency and in very organized fashion because of how we do our scheduling.
Thank you for that. And can we hear from Dr. Aronsohn next?
Sure. Of course, we have, a block schedule like the other programs do. We have requirements that we have to fulfill, and every resident needs to do a certain amount of every subspecialty as they go through training. And so our block schedule probably does not differ so much from other programs in terms of giving, starting the subspecialty rotations that in the second half of the CA1 year. But what may differ with us is that because we are a smaller program, such a large teaching hospital environment, it's not unusual for our, young residents, as soon as we see that they are advancing, we really keep a close eye, since we don't have 100 residents a year. We can keep a close eye on each resident, and once a resident is ready to go on to a more advanced case, we put them into those advanced cases. So it's not unusual if we have a resident one who's progressing very fast to do a Whipple or an open AAA or something that may in a more crowded program be reserved for a CA3 resident. We really try to personalize the learning experience of our residents by knowing where they are at any given time, where their skill level is at, because everybody learns to walk at a different pace, right? So, some residents need a little more time to get someplace. Some residents, get someplace a little bit faster than others. So we want everybody to be comfortable with what they're doing in the operating room and feel supported in the operating room, but we want to keep them challenged. And that's one of the ways that we try to keep them challenged along the CA1 to CA3 continuum. So that's pretty much how we, hand out the schedule. Every day is made by the floor leaders, who do have a block schedule for each resident. So they know if you're on vascular rotation, you're doing major vascular cases. If you're on OB, you're doing OB cases. We do a lot of complex OB. Our pain fellowship is not in the hospital, so it's not here. There's no competition for pain patients here. And our PEDS fellowship, we have 2 PEDS fellows a year, but we have a freestanding pediatric hospital. And we do that has 9 dedicated ORs there. We also do a lot of pediatrics at our ambulatory center. So there is no competition from the fellows because we just have, because of this freestanding pediatric hospital that we have, that does a lot of complex pediatric and syndromic patients. We have more than enough for the residents and the fellows. It's just not an issue.
Thank you so much for these answers. It's great to hear that the residents get exposed to a variety of cases that helps them be prepared to practice in any scenario. That's something important in the program. Going on to the next question. What role do CRNAs play in the education of residents, if any? And I will start with Dr. Schabel.
We have almost maybe 60 CRNAs here as a PD. I love them. There's just no way that I could do my protected didactics without them, because if you have 12 residents per year, that's 12 ORs, right, that you have to leave. And that could be tough to do on any given day. So our CRNAs do not educate our residents. Even though we have so many of them, when we're doing our introductory months or the rotations, they're not supervised by a CRNA. The CRNA's not next to them or anything like that. However, the CRNAs provide the clinical relief for them for not just education days. It's ASA. We're sending a huge slew of Stony Brook residents to ASA. The cases still go on. We can't tell the hospital, oh, sorry, we have to shut down for 3 days because we have a big conference. So the way that the head CRNA schedule does is they're clustering a lot of the shifts during ASA, or if it's for an in-training exam, or it's for a graduation party. So even like a social event, even if residents are on call, we try to have everybody in our program go to graduation, even a CA1 resident or so. So we have the CRNAs come in on the weekend and break them out for the party. They can dress up, have a good time, and then after the party is over, go back to call. So they kind of facilitate the education, I would say social events, but they don't really they don't teach them at all.
Thank you. And can we hear from Dr. Aronsohn next?
Sure. Yeah, I mean, I would like, in addition to what was just said, we do need our CRNAs to be able to cover for graduation ASA conferences, and we have like 4 education days a month, so those rooms need to be staffed. The program is, again, even if we didn't have the CRNAs, if those rooms weren't staffed by CRNAs, they'd be staffed by other attendings. It would just, the residents weren't there, nothing would change in the operating room at all. It would run just like it did before we had a residency program here. But one of they don't educate our residents, but one of the things that we do here that we think is very valuable is our residents work with CRNAs when they're on call, not in the same room, but they begin to, get some exposure, and we try to introduce how, when they graduate, if they end up practicing in a place where they'll be supervising CRNAs, how that supervision, relationship, which sometimes can be a little awkward, especially if the CRNA is old and the attending is new, young attending, occurs. And we try to educate them on, that relationship and how that supervision can take place in a comfortable way once they leave, because they will be responsible for being in a leadership position with CRNAs when they move on to practice, either after fellowship or if they're not doing a fellowship before a fellowship. So that is part of their education, learning how to effectively supervise CRNAs and work with CRNAs in a congenial environment, and the teamwork that has to go on between the anesthesiologist and the CRNA as they go out into practice. So that's education, and that is part of our education.
Thank you, Dr. Aronsohn. That's a great point. Learning how to work with multidisciplinary teams with mid-levels, definitely an important part of resident education. And can we hear from Dr. Block, please?
Sure. So a year ago, I wouldn't be able to answer this question because we didn't have CRNAs. We were a physician-only practice. Our CRNA program started this past December. So we have right now I believe we have about 15, and we have more coming in waves. And again, we rely on them for service gaps and for coverage to get residents out to cover cases so residents can get out for lecture. Our didactic time is in the afternoons at 4:30, usually two to three times per week. And so we've done a really good job of making sure that all residents are relieved from all clinical responsibilities for didactics on time, if not earlier, and as well for department conferences and M&Ms, which take place on Tuesday morning. Same here, our residents and CRNAs don't have any educational responsibilities for each other. We also have student nurse anesthetists, or RN, resident nurse anesthetists, as they're called now, that have just started as well. And so we're learning, their flow and their needs as well, but they don't, intersect or interfere with each other's learning. We do have, all of our Tuesday morning conferences, our department conferences and M&Ms and grand rounds are all joint. So they do sit in the same classroom together and have discussions and ask questions, which is very helpful because a lot of our CRNAs work at different places, so they bring perspectives from other places as well, and likewise with us to them. So that's how it's a work in progress, and next year I'll let you know how it's going.
Thank you for that. For the next question, I'm just kind of going to circle back to, the interview process and application process, specifically virtual interviews. And about interview days, what programming have you worked into the interview day to allow applicants to become more familiar with your program? And can I hear from Dr. Aronsohn?
Well, I'm going to say that, we do have a break. We hold our interview sessions in the morning and the afternoon, and between those two sessions, we have a virtual, meeting between a bunch of residents and people who are applying, who are interviewing that day. So, but that's a virtual thing. Most of that interaction takes place, though, in our virtual or live dinner, meet and greets, in the evening of or in between our two interview days, or our live dinners that occur between those two interview days. That's where applicants would get the most exposure, really, to the lion's share of our residents. And if it's a virtual meeting, that meeting occurs in a virtual group that has the ability to pair off into individual, one-on-one sessions with residents in our program. And if it's a live meeting, it's live. So am I answering your question? I'm not quite sure I hit the nail on the head of what you were asking, if I understood.
Yes, that answers the question. And can I hear from Dr. Schabel next?
It sounds very similar to our program. We have meet and greets the night before, where the applicants get FaceTime with several residents. No interviews are there. PD, I'm not part of any of that. It's meant to really be an open, honest communication to the applicants, for them to meet residents. Maybe they know some, they can see how the interactions between the residents. On interview day, we do morning and afternoon interviews. They have they receive a PowerPoint presentation from me, just giving them a lot of information about the program. And they also have a resident session built into the interview day. So they have more FaceTime with residents to ask questions. We show some pictures. We try to make the best we can in the virtual environment. Also, the websites, I think, are also pretty good on most programs. If you want to get more information, most websites have information for applicants to check out in advance of the interview or afterwards.
All right, thank you. And just to go over the question again, what interview day programming do you have planned to allow applicants to become more familiar with your program during virtual interviews? And can we hear from Dr. Block?
Sure. So what we'll do is I'll give a sort of a 20 or 30-minute PowerPoint presentation to a group of applicants in a virtual forum, just going over, the overview of our program, lots of pictures and things. I do update it regularly based upon the questions that people are asking, because it's a way to learn about what's important to them. And so we're always, tweaking it based upon, different questions that people are asking. Then they'll have their interview with myself and usually one other faculty member and one other resident. We just started having residents interview this year virtually. We did when it was in person. And then they'll have their own session like other programs do with just the residents. So it'll usually be at the end of the day, and it's residents only with applicants. We try and include residents in our internship year, so they get some perspective about that year as well. And so, yeah, that's what we do.
All right, thank you so much for all your responses. I'm going to pass it over back to Michael.
Okay, so I think we've made it through most of our pre-recorded questions. So I think we're going to switch to the online Slido. And I think it would be appropriate to ask one question to the residents and one question to our program directors joining us, and then we can have some closing remarks. So we'll start with the residents. So this is our first fielded question from the Slido, and it got 4 thumbs up. How does your program work to address residents' mental health and life balances? And we'll start with Dr. Klein.
Yeah, excellent question. Super important. Wellness is, we have a wellness program in our program. We have quarterly wellness events that all the residents come together. It's program sponsored. We usually do a fun activity. We've done Top Golf. We've done a Loud Luxury concert. We've done a whole host of events where the residents come together, spend the day together, fully by the program. Usually it's an event and dinner, and that kind of allows for an outlet. Again, we also have our quarterly meetings. The residents get together. It's usually, this, and again, allows for an environment for residents to share their feelings or anything that's going on. I think wellness is it's an individual thing. Everybody goes through their own struggles and tribulations in life, and that our program is super receptive to, residents' ongoings in their life. Is open door policy, our absence policy. No resident has ever been refused any time off or any services they needed to get through any situation they need. And we're super receptive to that. And I think that allows for a really great growing environment.
Okay, thank you so much. And can we hear from Dr. Tan?
Similar to what Dr. Klein said, we have wellness events organized and sponsored by the residency program. We have been to Topgolf, archery, recently bowling, and dinner events with the faculty members. We come together and spend some quality time together. We are also offered to take wellness days, 5 days in a year for any reason that we can just request in advance to take the day off and spend the day for any reason that we are offered to. And altogether, we also are offered by the Hackensack University Medical Center Graduate Medical Education, some phone numbers or people to talk to if we are experiencing an anxiety or any type of stress that we can reach out and get some help. But regardless, we are a small program, so we know each other and we help each other as well if we are having any problem in our daily lives too. We have a really close relationship with the faculty and also our program director, so we are really easy to reach out people if we need help in any term, like any type of difficulty we are facing in life. We can reach out and get help.
Okay. And Dr. Zhang?
Yeah, so wellness is a huge topic, and I think it's incredible that it's gotten so much more attention within the past few years. And I'd really like to echo something that Dr. Klein did touch upon by saying that wellness is highly individualized. Everyone has their own definition of wellness and what that means to them. And in addition to that, it also can't be forced. So we all have probably seen those like mandatory wellness lectures. Thankfully, none of that here. But I think Stony Brook does do a good job in terms of providing a variety of events to cater to all interests. And in addition, if those events, maybe if you happen to be a little bit more introverted and you kind of just like to do your own thing, also providing a little diversity in the sense of having some time to yourself and also taking days when you need it. There's great support and camaraderie among your co-residents. So the my fellow chief residents do a great job of finding coverage. That way, there aren't any gaps in the OR, and coverage is never an issue. Of course, we also do have professional resources. If you do want to speak to someone who is trained in that field, those resources are always there for you. And I think our GME representatives also do a good job of holding events once in a while for like snacks and lunch, and generally being very supportive. Our hospital also has a designated wellness area, so it's a safe, quiet space where if you need to decompress maybe after a tough situation, that is always available to the residents as well.
Thank you so much. And for our last question, we're going to go back to our program directors. And this question, I'll start with Dr. Block. How do you view gold versus silver signals?
It's a good question. Signaling is new to us. And so again, I look at, we tend to place emphasis on regional signaling. So I guess to the best of my knowledge, I could answer the question that we basically just look at regional, we look at regional signals. It's something that's newer for us. So I probably would defer to the other programs.
So I guess we'll pop next to Dr. Schabel.
So this is the first year of gold and silver. So was it 20? So ask me in 1 week. We should have this 1 week from now, and I can tell you what my emotional response to a gold or silver would be. We definitely will consider it, looking at the applications closely. I would think gold means you really, really, really are interested. Silver is like you're really interested. And I also understand that if there's no gold and no silver, you still may be interested, but just not maybe to the level, or you just didn't feel comfortable necessarily using one of those magic tickets for an interview. I do tell my own Stony Brook students here, like everyone's going to get an interview. I tell them, even if you really want to come here, don't use that signal on me. Use that elsewhere to express interest. So, you can see as many different programs as possible and try to get the best interview yield that you can. So it's new, don't really know. I don't have any evidence base to tell exactly how the impact it has or how it makes me feel. But overall, I think it's a good communication. It's allowing the applicant to share their interest in a program.
You have any thoughts on this, Dr. Aronsohn?
Yeah, I've thought about it a lot, but, I have not experienced the silver, tokens yet. So, last year we only had the gold, and, I think it's going to mean to us basically the same thing it means to the applicants who are sending them, that you're spending your gold tokens on, the places that you really want to notice you, and you're spending your silver tokens on places that you want to notice them to notice you, but not quite as much as the places that you set your gold tokens to. So I can't see us really interpreting any different than the intent is, and I think the intent is great, and I'm really looking forward to seeing if I practice what I'm preaching now when we actually, the applications come in and we see the gold and silver. But I think it is overall, gold or silver, a great way to let a program know that you really are interested in interviewing there, and we will take both gold and silver considerations very, very seriously when we send out invitations for interview.
Okay, thank you so much. I think this is a great place to stop and start wrapping up the event. So in closing, a huge thank you to Dr. Aronsohn, Dr. Schabel, and Dr. Block about speaking with us and sharing a little bit about your programs. It was wonderful to learn about you all. I hope that those who turned in learned as much as I did about, all these wonderful programs. It's also wonderful hearing from the residents that joined us today. It always is a great insight to hear from residents currently at the program. So again, thank you so much for taking the time to join us on your busy schedules tonight and taking a little more than an hour to, speak with all of us applying this year. And I also want to extend a thank you to our faculty advisors, Dr. Abramowitz, who I think has been in the Zoom call listening on, and Dr. Weber, who have supported us with the AIG at New York Medical College behind the scenes, being able to organize and run these virtual forums as well as other events throughout the year. So with that, I think this is a good place to stop. Thank you so much, everybody.
Thank
Thank
you.
you. It was a
you.
pleasure.
Thank you. Take
Thank
care,
you.
everybody.
Thank you.
Good night.